Hi everyone, here's the presentation from group 1. We had some very interesting discussions and found out that we all have great ambitions concerning these topics. So the hard part was to narrow it down. We all worked with breast cancer and agreed that there's a knowledge gap concerning tamoxifen treatment effect and adverse effects, including development of diabetes. Therefore, we would like to design a preclinical study on endocrine treatment response in lean and obese and risk of type 2 diabetes. I'll just we thought about designing 2 research arms and in vivo explorations and patient-oriented assessments. We want to test the tumor sensitivity to tamoxifen in lean and obese female mice with breast cancer. And this to further define risk prediction and to identify breast cancer patients at risk of developing type 2 diabetes. Furthermore, to determine whether the clinical response to endocrine treatment differ depending on body composition. And the primary endpoint should be tumor sensitivity. We want to test if it's possible to lower tamoxifen doses with lower grades of side effects. And secondary endpoints was to determine if long-term risk of developing diabetes is increased, and if it's associated to the tamoxifen dose. And by doing this, we should measure insulin, blood glucose, insulin-like growth factors, if possible, inflammatory parameters, and body fat. The method, we would have to generate lean and obese female mice and implant mature lean and obese female with human tumors. When the tumors reach approximately 100 cubic millimeters, we would want to randomize based on body composition within diet groups, and these groups should receive either no treatment, 0.5, 2, or 5 milligrams of tamoxifen. And the study should end after 8 weeks. At a study end, we would measure tumor size, tumor estrogen receptor, and progesterone receptor, and we would measure body mass and body composition, fasting insulin and glucose, maybe lipids, and uterine mass to confirm hormone presence. And biopsies could be collected from tumors in the interim to determine if tumor is responding at a molecular level. Hopefully these in vivo explorations could be referred to the clinical setting to better produce baseline measurements in patients before treatment, to have more focus on developing latent diabetes during treatment. Thank you.
Thank you for a nice presentation, very interesting study. I was thinking whether you thought about bringing other types of chemo into the picture and not just tamoxifen, and whether you also thought about maybe adding an exercise group, because that's also becomes apparent that exercise is also a good intervention both for tumor growth but also for metabolic health and obesity and so forth. Have you thought about any of these things?
Yes, exactly. We talked a lot about breast cancer treatment or cancer treatment in general. It's very hard to determine a true baseline because they receive all kinds of treatment, both surgery, chemotherapy, and endocrine treatment. My personal opinion is that when you can narrow it down to see what kind of treatment has different kind of effects. But if you look at the whole treatment period, you end up not knowing which kind of treatment has caused the adverse effects. So I think we have to narrow it down and look at each part of the treatment by itself. And yes, exercise is very interesting to look at, and it could be done in an experiment like this. But again, I think we know so little about these things, so we have to simplify the designs.
Hi, thank you very much for that nice presentation. So I'm wondering if, I'm not an oncologist, so excuse me if this is a naive question. So when tamoxifen is it administered per kilogram body weight, I'm assuming, to the patients, or how is it?
No, that's the randomization is done on body weight, but in each group we will administer different doses of tamoxifen.
Yeah. So
both in lean and obese mice.
Oh, yeah, but what I mean is in patient setting, when it is administered to patients.
Oh no, that's not. That's a standard dose to everyone.
So is there any knowledge about the biodistribution of tamoxifen in lean subjects compared to obese subjects? And other ways of measuring this in the mice?
Not to my knowledge.
I don't know very much about that. That's a really good question when we're trying to do drugs in mice and humans. So typically we've just measured it in the blood by mass spec or measured the uterus mass to confirm that lean and obese females have the same amount at least circulating, but it's possible that it collects in the adipose tissue as well, which is something that I haven't been able to explore. But yeah, that's a really good question.
Just to follow up on that, tamoxifen is a pre-drug that needs to be metabolized to become active. So the efficiency of the drug in different individuals also depend on the individual's genotype and ability to actually metabolize the tamoxifen correctly. So it's a good point there, that it may differ also dependent on the obesity setting.
Can I ask a question? In your last slide, you mentioned about the applicability of your findings to human patients. Could you maybe elaborate a little bit more how you plan to make that inference? Like, what are the parameters that you expect to project, and how exactly would it be done?
Yeah, that's a good question. Today, we don't even measure blood glucose prior to start of treatment. And actually, we don't know if that's a good measure to catch these vulnerable patients. Maybe it's the insulin levels we should measure or body composition, or who knows. But hopefully, by doing these preclinical studies, we could get some knowledge on that.
So what we talked a lot about was that we know there's this long-term risk for diabetes after tamoxifen treatment. And so the natural next question would be, can we reduce the dose of tamoxifen in patients so that it's still effective on the tumor, of course, which is the primary concern, but then it's not as bad for all the other metabolic tissues. So really what we tried to do is titrate in a dose and ask at what point is the kind of lowest dose we could go to see a tumor effect, but then also not necessarily see adverse metabolic effects. It's going to be difficult to translate doses directly from mice to humans, but it could provide evidence of a de-escalation or a dose lowering study, and provide evidence for co-monitoring metabolic outcomes with the during the 5 years of tamoxifen treatment. That's kind of what we were thinking about.
Thanks.
Can I ask something else?
Yes.
So about the sorry, I have my son coughing here. I have the question about since you're looking into the link to diabetes, have you thought then on checking the pancreas as well from the animals in terms of the different levels of tamoxifen, and then if you see any change on expression there?
Yeah, we did actually talk about that specifically. Christina asked that question within our group. Yeah, we would definitely take, I think from a mouse study, we would take every possible organ and blood vessels and everything to really see if we can figure out the target tissues, because they're likely, you know, the estrogen receptor is expressed all over the place, and there's likely to be a lot of different effects. So yeah, we would absolutely want to look at evidence that the pancreas may be altering its insulin secretion or something like that. I know in mice, the problem we run into is that they don't develop overt type 2 diabetes the way that humans do unless you really challenge them with a lot of different things. So we were planning to use glucose and insulin and some blood measures as outcomes, but the pancreas would be important to look at the tissue.
What about if you change the animal model and you change to guinea pig, that it actually relates more to the lipid metabolic profile of a human? Yeah.
Does it? Okay, I didn't know that. And
yeah,
you can do the cancer treatment studies even without the cancer in other model systems. I guess I'm not very familiar with how you would study cancer in a guinea pig, but we could certainly do cancer treatment studies and ask those metabolic questions. That would be really interesting. I didn't know that they were better.
They relate a lot more. Yeah, sure. Than rats and mice.
Yeah.
Thank you. Very nice presentation. My question was a bit related to Simon's. I was thinking about, or I was wondering whether you were planning to look on the liver and whether they have NASH. As I remember, I'm not quite sure, but I think that tamoxifen is metabolized in the liver, so this could be interesting maybe to see whether NASH is implicated in the effect of tamoxifen, and whether that could be a factor in order to change or reduce doses. Or I think at least it would be interesting to look at the liver tissue as well, insulin sensitivity in liver tissue.
Yeah, I agree. I think we should look, because hepatic steatosis, from my understanding, is something that's identified pretty early on after tamoxifen treatment starts in patients. So yeah, we would definitely take the livers and look for anything that we could and that would indicate steatosis. Lipid droplets probably, and maybe some fibrosis or something, I don't know. But yeah, that's a good point.
Yeah. So I was just circling back to that question about if the outcome was diabetes, that it could also be done in a more metabolically challenged mouse model, such as the OB or the DB mouse, and then you could see if it accelerates the development of type 2 diabetes? Because you know the endpoint will be type 2 diabetes in this model, but you might get an understanding of whether you will accelerate this process.
Yeah, that's one of the things that I think about too is these patients, like I say these patients, I'm not a doctor, I'm a PhD scientist, but my reading tells me that patients with obesity may be more prone to these bad effects of the drugs. And so that is potentially because of their underlying kind of almost maybe pre-diabetic sort of state. So it would be good to maybe do alongside a genetic model that's more aggressively pre-diabetic. That's a good idea. I don't mean to dominate my groups. So somebody else can unmute and talk if you want to.
Liz, you're doing great.
We said also during our discussions, because we started up with drawing up these very large studies and clinical trials that we wanted to conduct. And then we asked ourselves the question of how we should use these discussions, whether it was to design our dream study or whether we actually should use this opportunity now that we meet and interact with new researchers that share the same interest, to actually come up with ideas that we could realize after this workshop. So that's why we landed in both these this in vivo oriented realistic plans, and then the extrapolation of it when it comes into the clinical aspects, which would require much longer planning and longer follow-ups to be able to get the results out of that. So